public, not a public meeting. And if I can ask everybody in the normal fashion to mute their microphones unless they're speaking. But of course, if it's your item you're speaking to, please turn it on. Raise hands in the normal way through the raise hand process, and I'll try and make sure that I bring people in as much as I possibly can to the conversation. And thank you for your patience, really, and understanding that we've moved the board meeting online today rather than moving to Portishead. I think in light of the amber warning around the weather, and you've probably seen some of that on the news, it was probably a wise decision and safer for everybody, and we shouldn't travel unnecessarily unless we absolutely need to. So without further ado, I'll just move into apologies for today. So I've got John Cappock, Joe Hicks, Ruth Hughes, Eugenia Fele, and Will Warrender, and Stephen Peacock. So I'm looking at Rob, really, or Lauren, whether we've had any other apologies that I haven't captured there.
Joe Hicks,
Yeah,
Chair,
Joe.
But Sam Hill will join for the item. Jay, I think you're aware that Joe's off as well.
Yeah, so I thought I'd mention her, but Sam is here. So that's great. Thanks very much. Any other apologies I haven't captured?
I think Sue Doheny, if that's how you pronounce her surname, she's not here for the open session as well.
Oh, right, okay. So she was here this morning, but she's not with us this afternoon. I could hear a little bit of conversation there. Can you just double check that your mics are on mute before I move on to the agenda? So we've got the minutes of the agenda from the 5th of October. Is there anything anyone would like to raise on those minutes? Any inaccuracies or any points that doesn't reflect those minutes? No? Okay, thanks very much. So we got the actions from that meeting, two of which are for December's board, but there was one around the burden of reporting, Joe, I think, which you were going to pick up on winter planning.
Yeah, Shane, I'll pick it up at the next. Sorry, Jeff, I'll have to pick it up at the next winter group, which is Friday. I was off for a few weeks. So I haven't been able to do it.
Okay,
it remains open. I'll report back at the next meeting.
No, that's fine, Joe. Thanks. Anything else on the actions? Okay, I'll move us into the CEO's report then, Shane.
Thank you, Chair. Colleagues, as always, you've got the paper, so I'm not going to read it verbatim, obviously. And what I try to do, as you know, is to take three big things, as opposed to going through 101 things that have happened in the last month. For me, the three big things this month are one, which is looking at ourselves, but I really want to put a forward-looking focus on where we are taking the system to and the ICB to. So the first area is organisational structures. So people will know that the ICB as an organisation has to make considerable reductions in running costs, 30% reduction in running costs. And every month I have brought this to the board, so the board is aware of the progress. You will see that since we last met, we have consulted on the new executive structure. That new executive structure was consulted on and finalised, and we now have an embedded senior executive structure. It is our intention to have an organisational wide communication on Monday the 6th, where we'll be sharing that with every employee in the organisation through our usual comms channel we've called Have We Got News For You. That will go out on Monday, and that will explain what the new structures are in terms of the executive structure, what the new operating model is, and also will just allow people the opportunity to understand how the whole thing is starting to come together. Just also to make the board aware, we had a voluntary exit scheme open that has closed. We are now, the panel, myself as Chief Executive, Sarah as Deputy Chief Executive, and then Joe Hicks as Chief People Officer, have been reviewing those voluntary exit scheme applications, and we would hope over the next week to draw that to a close. Because quite clearly, as members will be aware, an important part of this is an opportunity to reduce cost, and voluntary exit scheme is one of the ways in which we can reduce cost. So that's in terms of where we are with our organisational restructure. We are still on target to go out to complete staff engagement on the new model and new structures in December running into January, because we have to have this completed in terms of by April 1st, 2024. If I can then move on to two other things which I feel are really important and are forward-looking, because it's important that, you know, NHS is tough, health and social care is tough, but I think there's two really important things to look forward to. I've included in the paper a piece of work that we have just started on in partnership with the AHSN, although I know, Steve, that they're not called AHSN anymore. And the whole idea is, can we start to create a system and culture of innovation within BNSSG? So you'll see in the paper, we are working in partnership with AHSN over this year to really try to understand what is innovation, how can it work within BNSSG. We've had lots and lots of innovative stuff happen before, but can we really get to the core of how we can become innovative, really truly innovative within BNSSG? And really, you can begin to see, you know, how do we change the mindset? How do we really look at all the parts of the innovation pathway, whether that be procurement, whether that be idea, that bringing to market, all of that, and really starting to drive innovation. And we're talking about four major pieces of work. We're talking about how do we develop mindset for innovation within BNSSG? How do we take some innovations that are already in existence and push them through BNSSG? How do we then take some of the significant challenges we have and apply innovation and those pull innovation through? And then other thing then is to really understand how we can fast track innovation, because we know quite clearly that an idea can take an awful long time to get into practice, and therefore how can we drive innovation into practice? And that, I think this is a really exciting part of our future driving forward, Chair, in terms of how do we really grab innovation and how do we push it forward. And then the third big thing I want to just reflect on is neurodiversity. Over the last month, I have presented at South Gloucestershire HOSC, for example. I've been heavily involved in North Somerset in terms of the SEND work that we are doing. And in fact, there's a SEND meeting after this meeting in South Gloucester. And no matter which way you come back to it, we as a system have a major challenge around neurodiversity and in particular diagnosis of autism. So I think it's important the board are aware we've kicked off a major piece of work to try to get underneath the autism diagnosis challenge, neurodiversity challenge. And this is a major piece of work, co-production with parents, carers and children and young people, to really see if we can completely re-engineer the way in which we help people, not just diagnose them, but help them when they need help with regards to neurodiversity. And it's a major piece of work. We have a waiting list for neurodiversity, which is over 3,500 for autism, over 3,500 people. We cannot deliver those people unless we completely re-engineer the way we do our service. And it's very exciting because this is a true system-wide challenge that isn't any part of our BNSSG system that isn't challenged with neurodiversity and autism. And therefore, for me, this is a really exciting major challenge that we need to overcome. So, Chair, there are three big things. I really do appreciate that we've got a challenge with winter still. I really do appreciate we've still got a real challenge on the tail of industrial action. And quite clearly, having received more notification from BMA last week, they do intend to go out to ballot again. So it doesn't take away from the fact there are some really core difficult things going on. But for me, I want to take this opportunity from a BNSSG perspective to take a positive look forward. Innovation is really important to us, and how we address the autism challenge is really important to us, Chair. I'm happy to take thoughts, comments and questions.
Okay, thanks, Shane. And you'll know that Shane's update has been circulated in paper copy as well. So any comments or questions for Shane on his update? Ellen. You're on mute, Ellen. No, we're not getting you. I'll move on to Deb and to Aisha, and then we'll come back to Ellen and see if we can get you in. So, Deb.
Thanks. And it was just to add, since that update that Shane's gone through on the Innovation Hub, there's also been a call for a health tech acceleration bid, which as a system, there's been a really great piece of joint working that's happened across the respiratory and cardiac teams in our acutes, across Serona, the voluntary sector and others, looking at putting together a bid that gives us the opportunity to go further forward to support our population who have both CVD and respiratory, to make sure that we're supporting people to be much more empowered to self-care and to deliver their care at home. So that's another thing that we hope to hear from the centre, that we've been successful, but that will potentially link into that work stream too. And it was just because there's been quite an odd communication approach with this. So if people have heard about it through lots of different routes, just to know it's linked into this.
Okay, thanks, Deb. And I'll come back to you last if I can. Your microphone's come up now, so it might well be that we've got you, but I'll bring Aisha in first.
Thank you. Just two things really. The first is that I actually really welcome the progress of innovation hubs. Thinking dynamically and changing the way we work is invaluable in keeping up with the changing needs of our population. The second thing was around the neurodiversity improvement project. So really pleased to read about it and to see that co-production engagement with children, young people, families, parents and carers is actually a real kind of golden thread, and it's embedded. I guess my worry is often the children and young people that we don't see in front of us, the children and young people not on our waiting list. So I'm just really keen to understand and just get some reassurance that you're going to capture the voices of those children, young people and families, as well as those who engage with the service.
Yeah, thanks, Aisha. I think the important thing is that we've gone to parents and carers groups initially in a really wide way to ask them to become involved. And you are right, most of those with regards to neurodiversity will be people who will have an obvious embedded interest because their child is either waiting or has been through the pathway, etc. So you are correct. We've started with a really broad group of parents and carers that hasn't gone to a wider group of children per se. Okay. Now, I'm more than happy. I know, Deb, you've been heavily involved in this. I don't know whether we are going to go to a wider group outside for this particular piece outside of. We absolutely are going to go wider in terms of the other areas of family and of children's and families work. But this particular piece, we've engaged with 3 parents and carers groups in both Bristol, North Somerset and South Gloss as the main part of co-production. But I don't know, Deb, whether the group's considered going wider than that.
So what I think it's a really, really important point, but what we've been trying to do with this is to keep the scope as narrow as possible. So we're really focused on the problem that we're trying to solve. I think for the broader piece around autism across the life course, it is about making sure that we've got that broader engagement. So it's not that we're not doing it, it's just for the focused piece of work, we want to make sure that the people who are most affected and are experiencing those problems now, we're designing the programme of work around the needs and the changes that they want to see. Otherwise, we broaden the scope too much and we don't get the same impact. So it will be in time, but just not for this piece of work.
Thanks, Deb.
Thank you.
Ellen.
Yeah, thanks. So thanks, Shane, for your update, and for Deb for sort of expanding a bit on that. Really applaud this piece of work. It's really fundamental. It's been an area that's been discussed at committee sort of quite a number of times. Could you say a little bit more about the delivery of this? I know it's a big piece of work, but when are we hoping to progress through the stages, and when would we expect to have some impact sort of on the ground on this?
Okay, we're coming to the end of the discovery phase at the moment, and it isn't something that we're going to do. We're going to take too long at. Okay, but I think it is important, as Deb said, to get a really deep understanding of the problem we're trying to solve, because we've tried to solve this lots and lots of times before and taken rapid action, which hasn't been sustainable. Now, so we're not talking about 2027, 28. We're talking about next year. But maybe Deb, you could explain what the next phase is past discovery.
Yeah, so the next phase, once we've done the discovery piece, is to look at the design, which then takes us into a broad set of options, reflecting the things that we've tried before, reflecting the things that have been tried in other parts of the country and also internationally, to try and make sure we can then narrow down the scope, so to be able to do some test. So that if you think about our gateway process, which is referenced in Shane's overview, it's taking us through that process. So normally we're saying it's a 12-week discovery process and then it's a 6-week design process. But with some things like this that are quite entrenched and complex, and it covers all elements of our system, including schools and as well as clinical and health components, we want to make sure that we do this well, so that we're going to spend potentially a little bit more time. So the first kind of PDSA cycles and tests will be into the new year, hopefully before the end of this financial year, but it might be taking us into next year before we see tangible results that we can actually evidence and demonstrate outcomes.
Okay, and will that come back here or to one of the committees, Deb?
I think it will go into the I think it's quality and performance that it will go into, because that's where it's being held at the moment. But then yes, absolutely, if it's something that the board would really like to see back because it's such a big issue, then of course we can bring it back here. And
if I may, Chair, I've made a very clear commitment through the meeting we had last week with North Somerset to Ofsted and others. This is an improvement programme that we take seriously at the highest level of the ICB, because this is something that is seriously disadvantaging our population at times. So I would be delighted whether it goes through the committee or maybe finds a space on the board, but this is one that we have to crack for our population.
Okay, thanks, Shane. Sue?
Lovely, yeah, thanks, Shane. And just to reiterate, obviously, Sirona's support in this as a provider of ASD services across BNSSG. We are absolutely committed to working with the system and equally committed to looking at how and radically looking at how we improve performance in this area. And Shane and I have spoken about that. So,
thanks, Sue. I mean, it sounds sensible then that's brought back into your committee, Ellen. And then we have a board update at a later stage on that as well. So yeah, it's a great commitment and needs to be done, doesn't it? Any other questions or comments on Shane's update to us? No. Okay, I'll move us on to the local maternity and neonatal system update. This is for us to consider the risk. This has obviously had a lot of airing at committees in the conversation about what needs to be done. But you will have seen reporting around the country on this in the last few weeks and months, and about how important this is to us. And I know that CQC are doing inspections, and I think they're in MBT today, I think they're coming in this week. So we do know that absolutely this is getting the warranted scrutiny it deserves. But Rosie, I think you're going to give us an update on where we are at the moment.
Yeah, thank you, Chair. Doing this in my role as the chair of our local maternity and neonatology system, supported ably by Layla, who's joined us today. Layla Tuma is our patient safety lead for maternity and neonatology and joined us earlier this year. Layla is a very experienced midwife, and so she gives us the twin benefit of helping us run the LMNS really effectively, as well as working alongside the clinical teams in both trusts, providing some peer review and support. As you say, the purpose of the conversation today is to give the board the assurance of the infrastructure the LMNS has to provide support to the trusts and the wider system to make sure we improve the outcomes for the women, children and families in our system. You had a huge volume of documents today. That was to make sure you had the background documentation to understand the pieces that Layla will take you through quite specifically today, so you can understand the expectations nationally and the changing direction around the quality safety of our local maternity services. Obviously, both the trusts are responsible for their performance and the outcomes of their patients, but the additionality of the LMNS is bringing together wider system partners to focus very clear on how we collaborate, how we learn together, how we improve outcomes, and how we act in service and hear the voice of our population. And there's a real feature in here around collaboration and learning, as well as peer review and kind of regular and continued oversight of all patient safety incidents and our performance and outcomes for our mums and babies. But I'm going to hand over to Layla. She's going to take us through kind of 3 or 4 of the big strategic drivers for maternity for the next few minutes. And then Layla and I'll very happily take questions from you all. So Layla, over to you.
Thank you, Rosie, and hello everyone. So I'm Layla, as Rosie said, and I'm bringing this presentation to board to give an update on our current position of our maternity and neonatal services within BNSSG. So firstly, I'd like to talk you through how we review all safety incidents with an emphasis on sharing learning and good practice. So we have alternate LM&S safety meetings every month. The safety and quality meeting has an inward focus. So the trusts bring their perinatal quality surveillance matrix, which tracks various data sets, such as number of preterm births, neonatal deaths, and any incidents that have occurred over the last month. All HSIB investigations would also be reviewed during this meeting. The meeting is chaired by myself and our specialist LM&S safety and quality obstetrician, and attended by maternity and neonatal senior management, obstetricians, safety and governance midwives, and our maternity and neonatal voice partnership lead. The response group meeting, which is the other meeting, focuses on our response to national strategies and targets, which I'm going to talk about shortly. In addition to this, we have an LM&S perinatal loss and stillbirth review study day, where we promote shared learning across the system following local investigations and review through the perinatal mortality review tool. And I'd really like to assure you today that we are well on target with the national ambition of reducing stillbirths by 50% by 2025 within BNSSG. To put that into context for you, in 2012, we had 58 stillbirths across BNSSG, and the latest data of 2022 shows that we had 24. This is a rate of 2.43 per 1,000 births within BNSSG, compared with the national figure of 3.3 per 1,000 births in the UK. However, we know that we must never be complacent, and we need to continue with all the initiatives to reduce this further. So as Rosie mentioned, the papers that you've received are quite extensive. So therefore, I'm going to highlight the main 3 strategies that maternity and neonatal services are focusing on this year. And that is the 3-year delivery plan, Saving Babies' Lives version 3, and the maternity incentive scheme year 5. This year, we've seen a change in policy, strategies and national drivers for maternity and neonatal services from NHS England. And although we are still working towards the national ambition to halve the rates of stillbirths, neonatal deaths and maternal death by 2025, we've moved away from the Better Birth strategy. And in April this year, the 3-year delivery plan was launched. The plan acknowledges all of the amazing work that has been delivered through the Maternity Transformation Programme, with the acknowledgement that we are now moving forward into a new programme which really focuses on safety. The 3-year delivery plan emphasises the importance of the LM&S and how this must be central to continue to move the work forward. Within the 3-year delivery plan, there's a strong emphasis of the joining of maternity and neonatal services and the quadumvirate leadership model, which is made up of the Chief Nursing Officer, Director of Midwifery, Lead Neonatal Consultant and Divisional Manager, which we also replicate within our LM&S structure. The 3-year delivery plan aims to prioritise safer, more personalised and more equitable care, and it brings together all of the actions that we've seen from the Ockenden report, reading the signals from Bill Kirkup, as well as the long-term plan. The plan has 4 chapters to provide focus and rationalise the asks from all of the different reports and plans. And these are listening to and working with families with compassion, growing, retaining and supporting our workforce, developing a culture of safety, learning and support, and standards and structures that underpin safer, more personalised and more equitable care. Each chapter contains 3 objectives, clearly setting out the ambition of what good looks like, and clearly determines what trusts, LM&Ss and NHS England must do to achieve these targets. A determining success section sets out all of the outcomes and progress measures at each level, which will demonstrate that the interventions are making a positive difference. And this includes both quantitative and qualitative measures, as well as regulatory backstops. Assurance processes have been streamlined and simplified to reduce the administrative burden on both trusts and systems. Within BNSSG, the LMNS is collaborating with the Acute Provider Collaborative to support the Trust to agree both individual and system action plans in response to the plan, following joint system workshops. Mapping and gap analysis have been completed by both the Trust and the LMNS with a What Good Looks Like section as an aspirational plan for the next 3 years. And as you will see in your papers, BNSSG are benchmarking really well against this, as we were already working towards a lot of these objectives prior to the plan being released. Maternity Services have been following the Saving Babies' Lives programme since its release of version 1 in 2016. The programme is designed to reduce stillbirth and neonatal death and has been developed by groups brought together by NHS England, including midwives, obstetricians and representatives from stillbirth charities. Version 3 was due to launch in March this year, but was actually delayed until June. And this is significant as there's a target that all trusts are fully compliant by March next year. So instead of a full year of working towards the new programme, it will actually only be 9 months. Building on the achievements of the previous iterations, version 3 includes a refresh of all existing elements, drawing on both national guidance and frontline learning to reduce unwarranted variation. The release of an implementation tool that all trusts and LMNSs must use will ensure that there is a standardisation of the evidence used for submission of compliance. This does mean, however, that there is an extensive increased requirement for audit evidence that we're currently working on, and I'd like to suggest that the progress of this comes back to board in March next year. Lastly, I'd like to talk to you about the Maternity Incentive Scheme, which is in its 5th year. The Year 5 standards were launched at the end of May, and we're currently in the process of agreed system meetings to ensure consistency of evidence and sharing of learning and best practice between the two trusts for achieving all 10 safety actions. The 3 actions that BNSSG are focusing on currently are the target of full compliance of Saving Babies' Lives, the fetal growth risk assessment and management action, with the LMNS leading a review of scan capacity and pathways, and the increased requirement of statutory training for all perinatal staff. This training includes multidisciplinary emergency scenario and fetal monitoring training, with the requirement increasing from 2.5 to 5 days a year. This is obviously positive from the point of view of increased training and learning, but will put pressure on the trust to release staff to attend training while maintaining a safe staffing level for clinical care. We must also be aware that although we have a current direction of travel, there will be another Ockenden report following the investigation into Nottingham Maternity Services, as well as the results of the statutory inquiry following the Lucy Letby case. Therefore, it is likely that the assurance processes and policies may well change again over the next year to 18 months. I'd also like to highlight that although we have seen a reduction in birth rate, there has been a significant increase in complexity, so the pressure on maternity services will not be decreasing. And this can feel amplified within our trusts, as we provide not only the highest level of neonatal care, but also provide the regional tertiary maternity and maternal and fetal medicine services, which is looking after the most poorly and complex mums and babies, which provides an added pressure on our maternity and neonatal bed and cot capacity, as well as general service provision. This also impacts on workforce, which is one of the biggest challenges faced by maternity and neonatal services, both nationally and locally. However, we are recognising this by having a dedicated retention and recruitment midwife within each trust. And I'd also like to tell you about a bespoke anti-racism training that has been developed within BNSSG, Black Maternity Matters, which is currently running with its 2nd cohort of multidisciplinary staff and receiving a lot of positive feedback, as well as multiple quality improvement initiatives that have come from it. So to conclude, I am confident that we have a strong infrastructure in place, but we must not be complacent and recognise that it will require continuous and ongoing effort. I would like to suggest that I bring the evaluation of the Black Maternity Matters, as well as our other maternity inequalities projects that we're undertaking within BNSSG, as well as the progress of the implementation of Saving Babies' Lives, back to you in March next year. Thank you very much for listening, and happy to take any questions.
Thank you, Layla.
Okay, thanks, Layla. Any comments or questions from board members on the reports? Alison.
Yeah, thanks very much, Rosie and Layla. Really important services in our patch, and a really important update. Sitting on the Outcomes Quality and Performance Committee, I think I do get assurance about the governance systems in place. And I take your point, Rosie, this isn't about performance. There are so many high profile failings, and I fear there'll be more, but unless we learn across the country. One of the key things for me, and I wondered whether you could just say a little bit more about it, is around really listening to the views of staff about how it feels to be a member of staff either in the maternity service or neonatal service, as well as the voice of the parent, family and the experience of the child. And where you see there are failings, it's the experience of staff that can sometimes be a trigger before outcomes become deteriorated. And I know there's a big emphasis on outcomes, which is important. So just a little bit more on really the systems in place for understanding as an LMNS what it feels like in such pressurised services, relationships between different types of clinical and non-clinical staff. I completely support the quad approach as well. It's a really good one. So just a little bit more on that would be really helpful, I think.
Shall I get started, Layla, and then you can come in? So I think that's one of the joys of Layla's post for a start off, because Layla joined us in January, and as I said, what she does is a mix of time running the LMNS, but actually working alongside our clinical teams regularly enough to kind of be seen closely alongside them. So that's one of our tests. I also know that both the chief nurses and the trust do patient safety walkabouts and are patient safety champions in their maternity services, and do that alongside exec board members. We also have the MNVP regularly joining some of those patient safety walkabouts and spending time alongside staff, and also listening to women both when they're inside the services, but also when they go and meet them within community groups. And our MNVP is now hosted by Health Watch, so Vicky may well want to add into that bit. We also do insight visits, and we visit each trust at least once a year on with quite a big team. And inside those visits, we all spend time sitting with different staff groups and talking about the team working, the culture, the how things are working inside both trusts. I think as well as that, the LMNS is a really strong place for those discussions. So we've had various, I think 3 or 4 study days over the last 18 months where we bring in colleagues from both services and from public health and elsewhere, and we explore subjects, and we have talked about culture through those settings. So I think, Alison, there's a variety of ways we do it, and that's kind of the point, because we know, don't we, that you know, if we just do it one way, it doesn't capture rich information. So I think, you know, as Layla said, we're not complacent. We will need to keep doing that, but there are a variety of ways in which we spend time inside the service alongside the teams, both from the LMNS, but both the trust chief nurses as well. Layla, have I missed anything?
I think you've covered it, Rosie. The only thing that I would just add to that is that we are undertaking our insight visits, as Rosie mentioned, in January this year. And last year, the insight visits were, we were tasked with making sure that they were focusing on the Ockenden immediate and essential actions. Whereas this year, it's been given more to systems to decide what we should look at. And we've decided as a system that we're very much going to focus on culture and what does it feel like to work in that organisation. And we're organising focus groups with multidisciplinary groups of staff to really understand that more and allow that sort of area of being able to speak up. But yeah.
So the other thing I'd add as well, and I'll bring Vicky in if that's all right, Chair, but our MVP are really important to this, because they again spend time alongside staff and people using our services. And we've benefited from investing a bit more into MNVP. We need to do some recruitment now. And so the task there will be to recruit extra MNV partners who represent our community effectively. So we get that spread across our different groups in our community. So we'll need to do some fairly targeted recruitment so we get the right people that are engaging alongside our staff, but also with our communities. But Vicky, I don't know if you wanted to add to that.
Vicky, do you want to come on this point before I bring Steve in? Is it the same point?
It is, yeah, it is.
Okay.
It was to just to add to that. It's partly to commend the LMNS for increasing the funding for maternity and neonatal voices as a partnership and bringing us on board to host it. I think, you know, the intention obviously is to make a very positive difference to how wide the engagement can progress and increase representation also of voices across the whole patch, and that will definitely, you know, we're in the early stages of recruitment, as Rosie said. We're going to be actually having a meeting tomorrow about some of this structure, and you know, the whole point will be to lead to quality improvements, more personalised care, safe, empathetic care. So yeah, that's we have a work plan now in place for the LMNS for the year.
Thanks, Vicky. That's really helpful. Steve.
Thanks, Chair, and thank you, Layla. That's really helpful and a very comprehensive report. I guess my challenge to all of us is that nationally there have been very high-profile reviews undertaken, and of course we do our own local regional reviews, and most of them point to some barriers, cultural issues in organisations where learning either isn't learnt and implemented, or voices are not heard. And I just wonder, whilst there's, I think, emerging really good evidence that teams are being supported and trained differently now and maybe empowered in different ways, I still think we've got to look a bit harder into the governance within our organisations, and in particular how we develop boards and executives to in effect engage in a different way, so that the early warning signs that are often evident, using the fantastic retroscope that we all love to use after an event, to actually help us identify issues very early and then intervene in appropriate ways. So I'm just challenging us, are we sure we're really going to tackle the cultural issues at different levels that mean that some of the learning that's been there for a long time doesn't really get sorted and embedded?
Thanks, Steve. Rosie, do you want to pick that up?
I'd love to, yeah, Steve, because I agree with you. And actually, probably the infrastructure around maternity is so strong now that actually, you know, that our visibility of incidents, our oversight of incidents, our reporting systems are strong. And many of those have come into place over the last 6 to 7 years, and Layla will be able to list them off for you. So it makes you relatively confident, you know, if you think about the Lucy Letby thing. However, you're right, there's the bigger question about, and so how do we hear, and how do we hear to listen properly? How do we really get underneath culture? And I've been talking to my chief nurse colleagues about inviting ourselves in to do a ICB Board seminar session just on that subject, so we could actually do, not specifically around maternity, but how do we, you're right, if you look at any of the big safety incidents, the same thing, whether it's Gosport, Shrewsbury and Telford, you name it, there's a bit about people were trying to raise a flag and not heard. And there's also, I think, a difference for us in an ICB board about what we need to be doing, which is different than what the trust boards need to be doing. So I'll be very pleased. I've asked Layla to work up a scope for that, and I'll be very pleased to work with my CNO colleagues and maybe other colleagues to lead a seminar session to discuss that, exactly that, and how do we act in order to understand and spot the signals rather than hearing the noise.
Thanks, Rosie. And I think it's been really important that we've had this at the board today. It is this item is for reassurance and for discussion. It's not asking us to make any decisions today. Is there anything anyone else would want to add, or any questions anyone's got in respect to what we've had presented to us? No, well, you know, this is a constant one, isn't it? And one that the Quality and Outcomes Committee need to make sure they're on top of. But I think what you've both described today does sound quite productive about the way forward. So we're really grateful. And Layla, thanks for your time today as well.
And can we come back in March, Jeff, so we can give you an update on our performance against the particular drivers for March, as well as our equity and equality work?
Yeah, I think you need to be reporting back into the Quality and Outcomes Committee.
Oh, yeah, absolutely.
And if the next report back into us then is in March, that's fine. or sooner or later, but it needs to be kept firmly on the regular plan. So I think that's one, Rob, we need to pick up on forward planning. Ellen.
Sorry, Jeff, you've just sort of said probably what I was going to say. So I'm quite happy for, as we have a regular rhythm within outcomes from performance and quality, we'll keep this under review. Thanks.
Okay, thanks, Ellen. And Rob, we just need to make sure that's on the forward plan. Okay, thank you everybody for that item. Really appreciate it. Can I move us on to the VCSE update and current arrangements then? You've had the paper circulated to you, but Colin's going to give us an update on where we are with it. Colin.
Thank you, Chair. I won't detain the board with a lengthy introduction because I know this is a really important and live issue, so I want to leave as much time for discussion and questions as possible. As always, I'll take the paper as read and I'll hand over to my colleagues, Ros Coxon and Rebecca Amir, to give you an opening remarks and then hand over for questions and comments. So over to Ros and Rebecca, if I may.
Thanks, Colin. Ros and Rebecca, do you want to introduce yourselves just in case that other board members don't know who you are?
Yeah, thank you, Chair. So I'm Ros Cox, Associate Director of Partnerships in the ICB, and Rebecca should be here.
Hi, I'm Rebecca Meir. I'm the Chief Exec at VOSCA. We're the Support and Development Agency for the voluntary, community and social enterprise sector in Bristol.
Great, thank you. So just to pull out a few key points from the paper, I think is what Rebecca and I would like to do today. So I think as people are aware, the ICS is a partnership between local authorities, the VCSE and the NHS. And the support, development and integration of the VCSE sector is vital if we're going to achieve our strategic objectives of improving population health and wellbeing. So building on the current VCSE engagement that's been happening at both local authority level for many years and also at locality partnership level, the Alliance is now starting to take shape. And it's designed to fulfil several roles, including that strategic interface with other partners within the ICS, exploring the development of a VCSE provider collaborative, and also identifying new funding opportunities across BNSSG, so from things like national funding bodies, provider collaboratives and other organisations. I think people will be aware from previous boards that 200k pump priming money has been allocated from the ICB Chairs Fund, and with additional money from NHS England, we've developed a memorandum of understanding which sets out what key actions will be delivered and by when. And I'm going to hand over to Rebecca now just to just give a bit of a progress on what we've been doing so far.
Thanks, Ros. Yes, so I think the main thing I wanted to say today is just how uniquely placed the VCSE sector is to achieve the really excellent aims around improving health and well-being, particularly for those most marginalised or who face disadvantage, because they're in the community already providing holistic, long-term and committed services. But the sector does have its challenges, and a lot of the challenges relate back to short-term and piecemeal funding streams. The sector is diverse and comes in all shapes and sizes and serves all types of communities and differing priorities as well, and is often led by communities as they seek their own solutions to things such as health inequalities. So I come from VOSCA. We are a VCSE sector infrastructure organisation in Bristol, and we've worked closely for a number of years with similar organisations across North Somerset and South Gloucestershire. In fact, I used to run this North Somerset one as well. And we were nominated by the VCSE Alliance Steering Group to be the host organisation to lead that establishment of this co-created VCSE Alliance. So as Ros said, 200k was awarded to help set up the VCSE Alliance from the ICB Chairs Fund. And there was also some additional funding we'd attracted from NHS England and Pathfinder that we were able to put in as well. The ICB back in February set out a 10-point plan to support the sector to operate as a strategic partner, and part of this is to have the VCSE Alliance steering group in place. The membership of the steering group, we have 18 organisations on the steering group, which is in an interim format. They consist of the locality partners from the VCSE sector, the infrastructure organisations, of which I come from one, and also thematic organisations, particularly those that are equalities led, that operate at place level. And so it's really sort of complementing and building on the work that already has taken place at locality partnership level. So our plans include setting up a partnership liaison group, which the VCSE Alliance will chair, to further improve all of the engagements and coordinate and strategically bring together all the different opportunities, whether that is grants or funding, investment, provision of services, and also support requests. And indeed, one of the measures of success will be about trying to attract diverse forms of funding as well. We are launching very soon, actually, with some workshops in partnership with Ros and her team on funding and investment and how that could be better improved, particularly around systematic approaches to how the VCSE sector across BNSSG is invested in order to improve health outcomes and wellbeing outcomes. And these will happen before Christmas, and then we will aim to have a new model in place for March. In terms of the sector, I think it's really important to note the sector has multiple roles to play for the system. And it also attracts income from a huge variety of sources. In fact, there are many organisations that we work with that are absolutely able to attract funding from the public and also from philanthropic grants, as well as public sector commissions. For the Alliance, we have established the following set of 3 pillars to set out our aims as a VCSE Alliance, and I will read them out here. So our first aim is to encourage and enable the VCSE sector to work in a coordinated way to inform policy, strategy and decision making around health and social care. Our second aim is to provide NHS and health providers and social care colleagues with a single route of contact, engagement and links to the community. And our third aim is to better position the VCSE sector to contribute to the design and delivery of integrated care. So I hope that's enough of an insight from me. I'm going to hand back to Ros.
Yep. Thank you, Rebecca. So in terms of the recommendations in the report, you'll see that there are 2. The first is to note the progress to date that we've been working on and the next steps in the VCSE development and working as a team, as Rebecca has said. And secondly, it's to, and importantly really, it's to approve the proposal for a VCSE representative to attend the ICB board as a non-voting member as per the ICB constitution. And the individual will be nominated by the sector. Thank you.
Thanks, Ros and Rebecca, and to Colin as well. And Dominic, I'll bring in a second, but I think it's probably worth me coming in at this point just to say we have invested some money in this because whilst we have such a disparate group of people across the third sector, to try and get those 3 points that Rebecca has covered around coordination, single point of contact, design and contribution would be very important. Those at the private board this morning will have heard me talk about the need to get third sector representation, but for that to be decided amongst the third and voluntary sector, because rather than us try and prescribe it. Now, we've tried to do that with the integrated care system, where the chair is rotated across our 3 local authorities. And we know that within our area, as Rebecca has touched on, we've got VANS and CVS in North Somerset and in South Gloucester. And ideally, this is going to be a tough ask for you, Rebecca, I know. We would like to try and get that single point of contact. There will always be a challenge around that involvement with the ICB, and that's perhaps about conflict of interest. But I actually think if we manage it in this way, then that deals with some of that, because it's much more of a representative voice rather than you attending and getting the benefit from a decision made by the ICB. So we need to make sure the governance is right on it. But I do think this is the way forward. And then the final point, which the the tumbleweed did move across the room a little bit, the ICP, when I mentioned this last week or the week before, which is, whilst the £200,000 might sound a lot of money, it's only enough to pump prime what we are starting, the work that's been done by Rebecca and her two colleagues in the Alliance to try and get us to this stage. That is not going to sustain what we need to do going forward. So we do need to have a conversation about how we fund that support in the future. And that's not for today, but that is one that's going to be need to be had amongst all of us as partners about the way that we do that. But I'm really encouraged that we've got to the stage we're at the moment. And a big thank you to Rebecca, but also to Ros and Colin in the coordination of that. Dominic.
Thanks, Jeff. My name is Dominic Hardesty. I'm Chief Exec of Avon and Wiltshire Mental Health Partnership Trust, or AWP. And as you'll know better than me, the voluntary sector isn't one thing, it's lots of things. And therefore my comment and question is specific to the bit of the subsystem that I'm most involved in and interested in around mental health, and it's sort of an offer and an ask. So the ask is, I just wanted to check that the mental health voluntary sector is as fully engaged with this as other parts of the voluntary sector. That's the ask, and the offer is if there's anything we can do as AWP to help, then absolutely we would love to do that, because our kind of vision, if you like, for future mental health provision is you won't really be able to see the join, but we're kind of a long way away from that. In some places we're stronger than others, but that's going to require a lot of heavy lifting by us and by the voluntary sector, so we need to do that together.
Thanks, Dominic. I don't know who's best to pick that up, whether it's Ros or Colin or Rebecca.
Yeah. Well,
Okay.
I just thought it might be simple just to say, yes, there is a representative from the Mental Health Alliance on our interim steering group. Yeah.
And thank you for your offer. Yeah. Thanks.
Okay, thanks, Dominic. Thanks, Rebecca. So I've got Shane, then Sue, then Jaya.
Thanks, Jeff. Thank you, Chair. And thanks, Rebecca and Rosa and Colin. Absolutely support this. I think there is no doubt that we around this table can bring all kinds of angles, but we can't bring the VCSE angle to the conversations we're having all the time. And we need, I use it for a stone in our shoe. You know, we need something that's constantly saying, don't forget, don't forget. Okay. And therefore I strongly support this. I think the challenge is the one that Dominic said. It is not a one-to-one relationship. You know, in terms of the nature of the voluntary community sector, it is just a series of networks of webs. So all this can be, I say all it can be, what it needs to be is nearly a broker into that system for us. You know, so it can't give answers and commitment at every board meeting and saying yes, it's the answer. But what it can do is take the question away and go and talk and engage and bring that intelligent input back into the board. So I absolutely strongly support it. And, you know, I look forward to it actually, because I think it will add value to our conversations.
Thanks, Shane. Points well made. Sue?
Thank you. Yeah, really delighted to hear about this piece of work, Rebecca and Ros, of course. And just to reiterate and offer our continued support from a Sirona's perspective to look at what else we can do to help and support this work. And I guess one of the really interesting things for us all to think about is how we capture the full range. And there's so many out there, aren't there, in terms of voluntary sector organisations and social enterprises that exist across the whole of our system, right down to a level of micro place. And it's how we really map that to ensure that we can, you know, grasp the nettle, so to speak, and realise the full benefit that engaging well with that ecosystem can really bring to the system and improved outcomes for our populations.
Great, thanks, Sue. Jaya?
Yeah, just to say, again, a really welcome VCSE Alliance. Rebecca and I have already met beforehand to talk about how we can get one of her leadership team to also represent at the People Committee level, really because obviously we want a system view of workforce and capacity, and we really need to start working together in terms of seeing what they can see and they can see what we can see, and the opportunities that will reveal. I'm quite excited about. So really, really good news on this front at this point. Thank you.
Thanks, Jaya. Dave?
Yeah, thanks, Jeff. And just to add similar comments, really, to welcome this report and the engagement. And I think it really does create the opportunity to build and strengthen those relationships that are already there in place through the local authorities and the infrastructure support that we've provided. And also actually that linkage back into locality partnerships where the VCSE sector is obviously a key player as well. So very much support this report. Thank you.
Thanks, Dave. Any other comments or questions from anybody? I mean, we wouldn't underestimate the challenge that's going to be in this to try and corral us all to a position where people are happy with the representation at the ICB. But as Shane said, we can see from all the conversations we had this morning that conversation needs to be there, and it's a missing part of the link at the moment. So I'm gaining from the board that people feel united in that view, to be honest. Is there anything else anybody wants to add? There's a list of bullet points on the paper. We're not being asked to agree anything here. We're just being asked to note progress. But there's a number of points there. So is there anything anybody wants to raise on any of those? Colin?
Well, just to say, just to reiterate that one of the recommendations is for the board to approve the invitation of a representative of the VCSE to join in attendance going forward to be nominated by the VCSE. Just wanted to, for the minutes, make sure everyone was happy with that.
Yeah, thanks, Colin. It is, and I think provided we follow the right process, that is a really sensible way forward. I think the challenge will be for Ros and Rebecca to and others to manage that process. And I think if we because I do know when we did that with the ICP, it took some time. So I would say to you, if this takes months rather than weeks to get the right position is what we need, rather than you feel pressure to rushing into reaching a decision around it, because we did that with the local authorities. I think they had a chance to discuss it and work it through themselves, and we came up with a really good solution for it. And I would encourage us to do the same with voluntary sector involvement in the ICB. But I'm hearing the door is open unless people have got a view to the contrary. Okay, thank you, everyone. That was a really good item. Anything more before I press on to system level access? No? Okay. So, Dave, you're going to take us through this, the BNSSG system level access.
Oh, I will certainly start the process, Chair. I'm conscious Jay has got her hand up. Is that from the last one? No, old. Okay. Colleagues, thank you. So I'd like to also welcome Jenny Bowker and Bev Howarth. Hi, Bev, to support this presentation, who have done a lot of the majority of the legwork behind that in collaboration with primary care colleagues across the system. Ruth was going to share this intro with me, but unfortunately can't be here today. So just it's a very detailed paper, as I'm sure board members will see. So we will try and be as succinct as we can in our summary to enable discussion. But it's my pleasure to present this system level improvement plan, which is in response to NHS England's delivery plan for recovering access to primary care that was published in May 23. As you'd have seen, the plan sets out an ambitious package of measures to help improve access and patient satisfaction with regard to primary care services. This is a first iteration and our first draft for the board this afternoon. This plan has and will continue to be a significant programme of work, as I'm sure you can appreciate, and will continue to be an iterative document and a live work programme, and will continue to evolve and develop over the coming weeks and months. ICBs were formally required to develop a system level access plan, system level improvement plan, and then bring to a public board within the time frame that we are here today. The draft has been discussed and shared and developed through a multitude of different fora, as you can see on the paper, including our primary care committee in September. I will ask Bev just to come in now. Bev's coordinated the majority of the content that you'll see across partners, as I've said, and I'm just going to ask Bev just to draw out some of the key successes within the improvement plan and some of those key challenges that we still need to address moving forward to make sure we address all areas of the improvement plan. We are asking the ICB board to approve the plan, and then we'll be back in March again with a further iteration and update on the plan. So with that as a intro, Bev, I'll just ask you then just to draw out those key points as I've set out.
Thank you, Dave, and thank you for your time today. I'm Bev Howarth, I'm the Deputy Head of Primary Care Development. As Dave says, it is a big programme of work, but we are not starting from scratch. We've been aware of the needs to work on our equity of access across the system for some time, and our practices have been working hard on this before the Access Recovery Plan was even published. And the paper gives a baseline position reflecting this work in the kind of priority areas of empowering patients, modern general practice, building capacity and cutting bureaucracy. So I will just draw out some of the key areas of progress and where work needs to continue. In terms of activity, we are above plan for the number of appointments delivered and on track to meet the national target. We're above average for our appointments within 14 days. We are also measured on same day work, and that is appointments, but it's important to really understand that the aim of the plan is for our patients to understand and know the outcome of their healthcare request on the same day, and not necessarily an appointment same day unless there is a clinical need. So quite a different thing and important, as that is why we're really working on having the right access routes in place to do this, and ensuring our practices are trained in managing change in processes and also effective triage. So we get the patient to the right place or the right person at the right time. And this is really important in the move away from not just seeing a GP, but making use of our widening MDT, but also important for continuity of care. So we now have access to data at practice level, so we are able to give a more targeted approach. The paper signals where these practices are in relation to deprivation across BNSSG, along with the details of the support and the training that's on offer. 71 out of our 76 practices have attended that training, covering all of our PCNs. We're obviously aiming for 100%, but even more important is actually supporting the embedding of that learning and sustainability. The paper also has details of specific health inequality pieces of work, such as implementing a process for the identification and management of our population at the highest risk of poor health outcomes. And we're working closely with Health Watch colleagues for insights, including some targeted work with 7 of our PCNs in areas of deprivation to support sharing of good practice. It's also worth noting that our community pharmacist consultation service has been incredibly successful, not just locally, but in comparison to the Southwest and also nationally. We've reached our target of 5,000 referrals a month, and now we're on a stretch target for 7,500. And it is important to understand this increased volume of activity when we talk about workforce. So whilst we're doing well in our efforts with recruitment to our additional roles, our GP numbers do continue to kind of fall, and we have a real challenge with this, as well as our nurses, and increasingly with our admin staff turnover. The paper gives the details of the initiatives that we've got in place at the moment to support recruitment and retention, as well as health and wellbeing, and also our comms plan to support practices and also to help our public understand these pressures and also the new ways of working, to try and manage expectations and behaviours when patients interact with our on our practice staff. In terms of digital, the recovery plan has a total triage aim enabled by digital, with a view to try to support freeing up time for our clinicians and admin staff, but also making life easier for those patients who can use digital mechanisms. And this encompasses patients having access to online records, where we've got 63, about 76 practices already live, 7 onboarding, and we're working with the remaining to do that. Use of the NHS app for the ability to book patients online, appointments online, and online consultation capability, where all of our practices have that in place at the moment. In terms of telephony, all of our practices are on cloud-based telephony, which is not the case around the country. And we are on track for 75% of our practices by the end of March to have the additional functionality of call waiting and call back. And 38% of our practices that have implemented this are really noticing the difference in that 8 a.m. rush, as patients are starting to understand the change in access and moving towards being more assured around that. We've got a few examples in the paper as well. It is a system plan, so we are working with our primary care, secondary care interface. We've established a system group to do this, chaired by our CMO, and they're meeting monthly with the kind of agreed priority areas of culture, as we've already talked about this afternoon, planned care, so by that I mean the fit notes, prescriptions, discharge summaries, advice and guidance, and urgent care as well. And that's just a bit of a snapshot of the progress and the work underway, with a lot more detail in the paper and an overarching summary of what the ask has been, the progress and our trajectories at the start. There's still a long way to go, and we're certainly not resting on our laurels. We do have some big challenges and risks. We're in the final year of the current general practice 5-year contract, and we're yet to understand the details of what the future is going to look like. As we all know, there are increasing costs generally in terms of cost of living, supplier costs, estate costs, along with our staff pay rises, which is a real risk really to our practice financial resilience. And potentially ultimately staff numbers for those staff supporting this access recovery work. The primary care, secondary care interface is key, as I've said, as an interdependency in regards to waiting lists. 20% of our activity in general practice is about accessing secondary care, about not having outpatient appointments and being on those waiting lists and being on hold really. So our next steps, as Dave said, as we would like to come back in March, is a stock take of where we are at the halfway point against our primary care network capacity and improvement plans, and updates on the kind of the support that we've continued to develop over the last 6 months, and some clear actions for delivery by the end of March for year 1. So lot to kind of get through in a short space of time. So hopefully that's a helpful overview, and I'll pause there for an opportunity for questions.
Okay, thanks, Beverly. Can I open it to board members then, where there's any questions or comments on what you've been presented? The papers are quite detailed around it. So I've got Shane, Alison, and then John, and then Jaya.
Thank you, Chair. First of all, just to thank you to everyone been involved, because this is a massive piece of work. My question is there anything more you need from us as a board to really move this on even further? We have a complete set of partners on this screen, and I appreciate this is the focus on GP, and I know that, but some of it, for example, you raised this issue of a lot of the contact is around waiting for outpatient related information back to the hospital, etc. So is there anything more you need from this board that we need to do to help you move that forward?
I Thank you, Shane. I think at this stage, with the establishment of the primary secondary care interface group as a first instance, and also we're establishing the integrated care at home board as well, where we're trying to bring all partners round the table. That is still in its infancy, both groups. So I welcome that ask, and if we can kind of hold that thought, see how those groups come, and if we need to come back to take you up on that offer and the board, then that would be most welcome.
If I can come in on that though, Bev, I think what we could do as a wider system is really think really carefully about general practice not having to be the hub through which everything has to go in order to access service, because there's an awful lot of stuff that gets bogged down and entrenched in process, unnecessary kind of red tape things. Oh, you'd have to go and see your GP for that. And actually, if we can have an ambition to make many more services direct access and take out that sort of central conduit function, that would ease a significant amount of work pressure in the general practice aspect of primary care to release capacity.
Okay, thanks, John. Alison, then Jay, and John, I don't know whether you've got another question. Have you, or was it just commenting on that point? You got another question? Oh, yeah, I'll take in turn then. So Alison, then back to John, and then Jay.
Thanks very much, and well done to Bev, Jenny, and Dave, the whole team. This is huge, and it's moved on, I think, since we saw it at the Primary Care Committee, which shows how dynamic it is. I was going to ask a variation on Shane's question because the success of this plan will help the overall system to be successful, and so I think it's in all our interests that this plan succeeds. And what were the areas where you needed external support? But I think you've answered that. And I wanted to make a comment about the primary secondary care interface, because there are clearly some actions that if they are undertaken outside of primary care will help. And I really like Jo Medhurst's approach to this, because she went into it in some detail about starting to build really good, solid relationships between primary and secondary care, particularly clinicians who over time have lost that personal touch with each other perhaps a little bit. Jo will probably say it a bit better, but this is what I heard. So actually building a really positive relationship is bound to help for all sorts of things. And I guess the balance for that is building those relationships and taking time, and then also delivering some quick wins. So one of the areas, John, that is quite clear is that consultants should be able to do consultant-to-consultant referral and not go back into primary care. Now, Jo building up what feels like a very positive culture change across secondary and primary care will help, and that will be a tangible within it. So I just want to say I really liked that approach, and I hope it gives a best chance of some success when people start talking to each other across the divide.
Thanks, Alison. John, did you want to come back in?
No, it was a separate point, but I'm next up anyway, I think, am I?
Yeah, John, do you want to come in now, and then I'll bring in.
Yeah, thank you. I was really just to express my thanks to Bev and Jenny for the way in which you've approached this, and for the engagement and inclusivity of general practice in drawing this up. And I particularly wanted to thank you for mentioning the administrative staff in this situation, because they are key to the first point of call through which patients come into the practice, and a thriving, resilient, supported workforce at that front of house function within practices is absolutely essential for us to be able to deliver good access. It's a massively stressful and pressured job for these people. They work in the local areas that they also live in, so the people that they interact with are their neighbours as well as patients of the organisations, and we all know that patients, when they're ill, will have much greater increased levels of anxiety and frustration and irritation potentially with access to care, and it can create a very emotional charged environment, and so these people do a fantastic job in trying to manage patients' expectation in a fair and reasonable way, and recruitment and retention in that area is very, very difficult for us at the moment. Staff turnover is huge because of the burnout, the pressure, the stress, the anxiety, particularly if you have a challenging interaction with a patient who may not feel that they're getting the access to what they believe they need, and so that really is a core part of how we can deliver this improvement, to make sure that we all work together, both as patients and as care providers, to ensure that people treat each other with mutual support and respect, and so I'm grateful to you for acknowledging their key role in delivering this, and we all need to be cognizant of the essential nature of that in our practices.
Yeah, thanks, John, and I think that would be reinforced as well with the whole of the board about the support for our frontline staff. There's a point well made. Thanks, John. I've got Jay and then Ellen.
Thanks, Chair. So again, really welcome this work in terms of improving access. I am wondering whether or not the work in progress is visible to our public. I mean, just going back to John's point about how our reception staff are treated and how vital they are to making sure the whole system works, perhaps there's a communication piece that could be going on in surgeries and pharmacies and other places to help them understand that things are being worked on, and perhaps using a system voice so that there's an awareness of us all working together. I'm just wondering really about the comms piece around this that could help to ease some of that.
Thanks. Yes, we actually started this before the recovery plan. So we have a local comms and engagement plan where we've got videos, we've been out on buses, and really reaching out to our communities with helping with understanding processes and all of the wider MDT roles as well. So we started that in the lead up to winter last year, and we've been building on that since, but also trying to align it with the national campaign and the national toolkit that has come out, which it has got a series of modules to try and help. We've also tried to provide kind of bespoke messaging as well, because we certainly have had challenges with practices trying to understand the models themselves and how best to communicate that as well, providing assurance that actually access is still available through all routes, even with the kind of the changes. So I think that's a really valid point that you've brought up, and we will continue to do that and maybe make that more widely known across system partners as well. I think that's a valid point. Thank you.
Thanks, Beverly. Jenny, did you want to come in on this point?
Yes, I was just going to reiterate that even though we've got work in train, communications, it's got to be an ongoing effort. Jay, you're quite right. It's not just a one campaign and then it's done. It's something we have to keep working on. So absolutely take that on board, and that's what we will be doing. Brilliant. Thank you, Jenny.
Okay, thanks, Jenny. Ellen.
Thanks, Jeff. Can I just thank Bev, Dave, Jenny for this great piece of work. I obviously fed in at PCC, but I just thanks again for the work. I'm struck by the comment you made, Bev, on GP numbers continue to fall. Just wanted to understand a bit more about the trend, and if we were to project this forward, what would we be looking at in sort of 12 to 18 months' time? I think that links very closely into what John was talking about, and how, you know, we make sure that various services are signposted in different ways. How do we compare to other systems? Is there anybody out there, you know, I think we're doing some fantastic work, but is there anybody out there that's actually had any breakthroughs in this area? So that was my general sort of area of interest.
Thanks, Ellen, and thank you for your input at PCC as well. It's really helpful. So we are doing exactly that in terms of the kind of the 12 to 18 months future predictions for our workforce as part of our operational planning and the review of our joint forward plan. It's really difficult. It's really difficult with the levels of unknown at the moment, but we do keep track of our kind of seasonality, if you like, and also we're working hard to try and put that trajectories on. And that links in with our retention and recruitment initiatives that we have in place. So we've kind of got fellows and mentors. And so we're trying to triangulate those coming on board, trainees coming on board. And we've got a really good record in this area of our trainees staying in the area as well. So that's what we're trying to kind of boost to help with those numbers. In terms of how we compare to other systems, we have monthly meetings with our other system partners in the Southwest to share good practice and to share ideas. And we've had also on top of that a series of kind of webinars where we get together and go into a little bit more detail around specific areas, because the challenges are in the main the same for many organisations, and so that process is in place, but sadly everyone's in the same boat really. But we do go to events where we share case studies and try and look at how applicable that is for our own demographic and our own patient needs. So yes, that is in place at the moment, but it's always a good reminder to make sure that we can do more and look wider, to kind of buddy up with similar areas. Absolutely.
Thanks, Beverly. It's really helpful. Dave.
I'll just only add to that, and I think that's one of the challenges, obviously, with primary care workforce. We have 77 independent, businesses, so that collation of workforce data is much more difficult. But I agree, it is a critical risk for us and our system. And I propose that, I propose we actually have let's have a deep dive into it through PCC. And actually look at our workforce efforts across the patch, and we'll bring in the training hub to be part of that. So let Jeff, if that's okay, let's action that and let's really dig into that through PCC routes.
Thanks, Dave.
Okay, thanks. Sorry.
And just to come in, and I know that Joe's not here today, but Sam is, but we're also linking in with the wider people directorate to make sure that all of our system workforce plans are inclusive of primary care as well, because it is across the board and there's much more we can do in collaboration, I think, and that will tie in with the workforce plan for our system.
Okay, thanks, Beverly. So we're being asked today to approve the system access improvement plan, accepting that obviously Alison will pick up oversight of this within the PCC anyway. Is there anybody who has got a dissenting voice around agreeing the plan? Okay, well, thank you, Jenny. Thank you, and Beverly, thank you for your time today. I mean, you've really put some flesh on the bones there and helped Dave out in that explanation. And I think it's really important for us, and we can see how that work is going forward and the amount of effort that's gone into it. So a big thank you.
Thank you, everybody, for your input and your time.
Can I move us on then to freedom to speak up, the policy change on that? Shane, I think you're going to speak to this, are you?
Yeah, I can. I mean, obviously, Joe Hicks would have spoken to it, but Joe's not here. So, colleagues, you have the paper, and I think Sam's on the call as well if Sam needs to come in. We have the paper, and you can see, I mean, more than ever, the importance of freedom to speak up. And I think, recent, whether that's Lucy Letby or other elements of health and social care. We have put this through our corporate policy review group, the staff partnership forum, and also the people committee. Okay, so this is coming to a sort of a final approval, Chair, through today. So it has been through a number of channels. You can see from the front cover, it has been updated in line with NHSE policy guidance. It's also been updated in terms of, bringing up to date a policy with new contacts, etc. I think what's interesting is the training element is being updated as well. Speak up, listen up, follow up, and that is so important. There's no point listening if we can't do something with what we've heard. So, Chair, it's been through, say, policy group, staff partnership forum, and the people committee. It is there for final approval, but it is a really important part of our architecture. Have we got news for you? Last week, Dave, as in Dave Jarrett, also presented to the organisation in terms of his role as being a guardian, and it's something that we know from our own staff surveys in the ICB, because it's an ICB, not an ICS issue today. For our own surveys from an ICB, we still have people who say, well, they actually wouldn't know where to go or wouldn't feel comfortable where to go if they wanted to speak up, and that's why this policy is really, really important. So I'm more than happy to take questions. Sam is on the call to take questions about the policy as well, Jeff.
Shane, I think you made the point about how important this is for us. Is there any significant changes from where we've been up until now with our policy? I mean, I can't see them highlighted in the paper, but and I know it's had a lot of discussion. We've picked up national templates and national recommendations, so there may be a lot. But is there anything that is a significant departure or change of direction from where we were previously?
I don't believe it's a significant departure. I think an emphasis on the executive level guardians and the importance of that. There's an emphasis on training. It's not a massive departure. I mean, Sam, I wouldn't see it being a departure, but
that would be my view, Shane, and that's the key changes that I've listed on the front of the covering paper, Jeff. So it's not a departure. It's maybe a more robustness in some of the content.
Okay, and they look very sensible and straightforward, don't they? So has anybody got any comments or views on the policy? Only to say that I think it's important that we state how important this is for us, Shane, the point that you made, and that we capture that in the minutes as well. Jay and then Steve.
Thank you. I recognise this is very sensitive because obviously this is whistleblowing. This is how we're approaching it. I'm wondering about the data. So obviously data will come in terms of highlights of issues into the People Directorate, and there's an opportunity there to see whether or not there are things going wrong, and how we might be able to fix them without violating any kind of privacy or anonymity. Is there a plan for that? How are we going to make use of this information on a broader kind of let's fix stuff as a system? Is that, where is that happening?
Jane, you're happy for me to so we will Jay, we will hold that in the People Directorate in the same way as we would with other HR related issues around things like grievances and those kind of areas, so that we can, as we need to, bring that that data to the forefront if we need to report, for example, at People Committee, if there are any trends that we're seeing that need to be addressed in that way.
Okay, thank you. We'll look forward to the progress on that. Thank you.
Can I think for a point of clarification, though, Jaya, this is an ICB policy, not an ICS policy.
Yeah.
So for a point of clarification, this will be those that come through our organisation about our organisation. I think it opens up a really interesting conversation about, as a system, how do we know we are learning and improving as a result of people feeling they have the freedom to speak up. That isn't what this is about, but it does open an interesting conversation that the People Committee might want to consider.
Learning, that's right.
I think that's a good point, Jen, because people will always ask, or at a time when we get things wrong, I didn't know where to go, and what options do they have, and do you have an option outside of your organisation? Well, of course you do, but what are they? And so, yeah, good point, Chair. Steve.
Similar point, thanks, Jeff, and that is that lots of organisations have got these sorts of policies. The proof of the policy is if people trust the policy and can see the actions that flow as a result of speaking up and speaking out. So I think however we do it, we'll need to test ourselves to make sure that it's working. And that's partly about people understanding that it exists, but then it is being used and the loops are being completed.
Right, thanks, Steve. I got Dominic and Dave.
Yeah, a partial answer to the earlier questions in two parts. Firstly, there is a regional Freedom to Speak Up Guardians Forum, which happens to be chaired by AWP's Freedom to Speak Up Guardian, who's a real firebrand, and she brings that same energy into the regional forum that she brings into our own organisation, where I would just like to say, for the record, we have over 150 Freedom to Speak Up Guardians. But secondly, the key one to track for those who don't know is in the staff survey, where there is a range of questions specifically about this, and you can see whether organisations are tracking up or down and moving the dial, etc. So it's definitely one that we can monitor in each organisation and across the ICS in a standardised way.
Thanks, Dominic. And perhaps that's one, Jay, you might want to pull out from the staff survey for the People Committee.
Yeah, I'm taking that now. Thanks.
Okay, Dave.
Just to come back on Steve's point. So myself and Sarah have been I think we were champions before, but we're now guardians for the last 3 years. And I think, Steve, it's about ensuring that people, as well as knowing that something happens, it's just continuing to re-emphasise the routes to sharing information and to speaking up. And so, as Shane said, we did a staff session last week. We just need to keep it going. That all routes are open, including the freedom to speak up route. And you're dead right. Evidence that something happens as a consequence is will encourage more to speak up. So just to reiterate, we'll continue to communicate and share this message.
Okay, thanks, Dave. So we note the change in the policy. I think we've had a good discussion about the importance and the broadening of it, and also the monitoring as well. Is there anything else anyone would like to add? So I'm taking as a groundswell of support for the changes to the policy, and we'd approve it. Okay, great, thanks very much. So we've got one item before we take a short break, and then we'll come back into the committee updates. So the final item is the strategy update. So Colin.
Thanks, Jeff. And in the interest of time, if I may, the paper essentially covers 4 topics. I'll go through those all at once and then take comments and questions at the end, if that's okay, just to make sure we get everything in within the time. So looking at the recommendations of the paper, the first one is around the detail in section 2 about a proposal for this board to have a development session with the Integrated Care Partnership to develop greater understanding and specificity around the relative roles and responsibilities within the integrated care system of those 2 groups. This is something the Integrated Care Partnership has also been discussing and is in favour of. We've engaged the LGA, the Local Government Association, to facilitate a session which is penciled in for the 11th of January, leading on, I hope in time, to a second wider event, which includes health and wellbeing boards and healthcare improvement groups as a second stage. But that's perhaps for a future discussion. So the first recommendation is that there's an approval of the board to progress that piece of work, which is being developed at the moment. The second one is around a set of strategic investment principles for the system, which has been discussed from this board previously in closed session, and the principles themselves that have been developed in partnership between local authority and NHS colleagues are contained for your reference in Appendix 2. And the recommendation there is to adopt those principles as a first set, iteration to be refined in practice, and on the basis of that to approve an amendment to our covering paper, so that every paper that comes to the board from now on, the question is asked, how does this proposal relate to our strategic investment principles, which are essentially about the aspiration of the system to develop a more proactive, anticipatory and preventative investment approach. The third element of the paper is around the development and implementation of strategic priorities following in the summer the publication of our integrated care strategy. And this builds on conversations that have been had at our strategic network and at our system executive group this week, and a variety of other groups. And essentially what it's about is the so what bit of the strategy. So what is actually going to be different? What are we going to do differently as a system, and what are we going to prioritise and focus on? The strategy that was published in the summer already narrowed this down to a large extent by the publication of 9 commitments, and they're included in section 4. They're a mixture of behavioural issues such as smoking and substance use, some disease-based or condition-based elements such as cancer and cardiovascular disease, bookended by some life stage stuff in terms of the first 1001 days of life and end of life as well, which is the 9th commitment. So the question is, over the course of our 5-year strategy, can we have a rolling process of prioritisation to focus on a smaller subset of these commitments at any one time? And there's been work to do that, but I think there is still some sort of high-level leadership required to agree which commitments we go after first. And under Figure 1, you'll see a table where we've attempted to map how different commitments in the strategy interface with one another, because of course they're not mutually exclusive by any means. And within needs assessment work that's been published in the system recently, we've introduced the concept of clustering, where things come together in individuals and in communities. So from that, underneath there is a potential under Table 1 to start to think about some first order priorities. As I say, all of them will be addressed over the course of the 5 years of the strategy, and you can see what they are in terms of cardiovascular disease, painful conditions, and support for older people towards the end of their life, which I think is a key strategic challenge for us to get that right, given our demographic changes that are forecast within the system. There is also one around the first 1,000 days, which I think is the broadest of those categories, and there are some ideas that have been explored there. In terms of next steps, the idea would be to test with the system these proposed priorities through key groups such as the Health and Care Professional Executive, the Health and Care Improvement Groups, and Health and Wellbeing Boards, to come back to this board with a final set of first order priorities for agreement to be coordinated and driven by the System Executive Group. And then finally, and thank you for your forbearance on this, there's a piece of formative work for information that I've been working on for a little while, and I've had recent very constructive discussions with Dave Jarrett and Joe Medhurst around the development of a community health worker model. And this is about what will be different, how could we implement and sort of support the delivery of our priorities. And I think I'll finish by just saying that there are some opportunities in a model such as this to hit a number of objectives, such as social and economic development by recruiting new workforce from our most challenged communities, which in turn, if we get this right, could reduce challenges to our existing health and care workforce, led by the VCSE. So it speaks very much to the VCSE development and sustainability piece, driven and owned by locality partnerships within a holistic and preventative model of care. There is some evidence base for this model, and there are a number of other systems across the country that are starting to adopt it. For example, Cornwall Integrated Care System are investing heavily in this model, so I think it bears further work. And actually, just for full disclosure, we do have a small pilot already running that's been funded by the Academic Health Science Network in the Western locality. So it will be important to learn the lessons from that smaller piece of work. But that was really just to give the board a flavour of some of the options and the proposals being worked up in service of the deliverability of the strategy. I realise I've covered a lot of ground there, Chair, in a short amount of time, so I'll pause there, thank people for their attention, and ask if there's any questions or comments on the back of that summary.
Colin, there is a lot in there, and you'll have seen the papers being circulated. Colin's run us through those 4 key points for discussion. There is a lot in there, and you know, but we do need to do it justice, because it is going to set out the way that we progress and the way that we move forward. So it's really important for us. Shane, I don't know whether you've got an observation or a comment on what Colin's just presented.
So I think first of all, this is a culmination of a lot of thought and work has gone into this. I think what's interesting is that the idea of the ICB ICP partnership meeting is certainly non-controversial, and in terms of the investment proposals, I think it would be really helpful to amend the board governing paper and the board covering papers so that we can look at that. In terms of the principles and what do we do first, it was interesting in terms of recommendations, because Colin came along to the system exec group on Tuesday. That's where, as chief executives, we meet to look in more detail at this. I think it's fair to say we need to take these back into our organizations a bit. I think it was the way we describe it, because to use your own term, Colin, we're not short of good things to do. Okay, so we could do all 9 of these, or we could do 2 of them, but then the other 7, why not? Okay, so we've had quite a very good discussion, and I think the idea of the clustering is really helpful. So it helped us focus as chief executives. It makes sense. The challenge we had is in how do we connect all of, say we pick the top 3 as described. Okay, so cardiovascular, etc. How do we turn it into reality of delivery? And is it through the health and care improvement groups? Is it through our own organizations? And actually sort of a model that Dominic sort of said, well, we could have the 3 of them, or the 4 of them, include early years. And then you could have each organization say, what's each organization's contribution to the 4? You could have each of the health and care improvement groups and say, what's their contribution to the 4? So we just need to work through the how we deliver. All of the things in our strategies are the right thing to do. Okay, so we want to get to all 9. This is a question about where do we start this year, and you could start anywhere, but the likes of cardiovascular, the likes of early years, there's evidence to suggest they are the places we should start. But as I say, we spent quite a bit of time on Tuesday as chief executives, and it's not as simple as saying we'll just run with that. There was a little bit more work to be done, a little bit more socializing this back in organizations, so we all feel comfortable that the top 4 are the top 4, Jeff. And I think, so I don't think we're quite at the point where we could say today, absolutely, those top 4 are right, let's get cracking. But we've certainly, as chief executives, started a lot of good conversation in that space, and we're not far away from being able to say that. But I don't think you could approve that today. And I know Joe was at the meeting and Dave Perry was at the meeting. I see their hands have gone up as well. So I mean, I would value their thoughts and comments as well, Chair.
Okay, thanks, Shane. So I'll open up to questions, but Joe first, then Dave, then I'll bring Colin in.
Mine's less of a question, just wanted to build on what Shane was saying in terms of the conversation yesterday. I think from a local authority perspective, what I was reflecting on is sometimes the way we've laid this out feels quite medical as well. And actually as a system, it's about what's the impact for our population and where we're going to get the biggest impact from those particular areas that we're targeting most. And I guess there's something as well for me as, representing as a board member, not just, I suppose, coastal communities, but those who are deprived as well in the most deprived areas, how you make that biggest impact for those that are maybe, impacted, I guess, by all 9 priorities. So I guess that was the challenge for us. There's different lenses you could look through, which is population-wide health, but also maybe targeted as well. And hence the need for us to do a bit more reflection within our own organisations and to consider that kind of system-wide, but population and targeted point as well.
Okay, Joe, that's really helpful. Thanks. Dave?
Yeah, thanks, Jeff. And just so obviously confirm my support for both Shane and Joe's comments, so I won't repeat those. I guess just a couple of additional ones from my perspective. I'm assuming that as owners of the strategy itself, the ICB board will be part of that iteration as we go through any prioritisation process, so that they're cited on that as well. I guess the other thing, and this will be in the narrative for me, is that if we do start to move forward focusing on 3 or 4, what we don't do is imply that nothing's happening on the remaining sets, because obviously there's a lot of work that's going on across all 9 at the moment, and this is around about bringing added value and focus around a smaller number. So I think it's important that we don't sort of accidentally say that, just because we're not focusing on those 3 or 4, that there's no work going on. And then just finally, in respect of the final element of that, which is the community health workers, and the intention that in effect these are owned by the locality partnerships moving forward. I'm conscious at this point in time, outside of the Western locality, there's been little socialisation of that model with the localities. So I think the next step is probably an important one, which is actually to start that socialisation with the localities, and ensure that we're learning any feedback or lesson that come from the Western pilot itself moving forward, and then enable them to do that careful consideration with the system around about the evidence-based population reach impact of that model before any final sort of decision is taken. But yeah, supportive of the paper, and well done, Colin.
Thanks, Dave. And Colin, before I bring you in, perhaps we need to think about those points and how we're having that conversation with the ICP about prioritisation. It's probably a critical one, isn't it? Colin, over to you, and then Vicky.
Just to say, very helpful points. All I was going to add was that just to clarify, and this is probably loose drafting on my part, the recommendation of the board is to approve the development of the priorities, not to approve the priorities as is it's this one or that one today. It was really to say to the board, are you happy to proceed on this basis, that we use the clustering model to develop in partnership across the system the final list of the first order priorities within a wider roadmap for all 9 to be addressed comprehensively across the 5-year period.
Thanks, Colin. Vicky?
Yeah, I just wondered, as a principle, in terms of when the priorities are clearer and those are sort of going forward, whether the system will be sort of being in touch with communities to, access the insights, and particularly sort of marginalised communities there, so that it's not a piece of work that goes ahead without them. That's my main interest, and I don't think I've seen that yet in any of this planning, but I know that how is part of what Shane was talking about, but I think it's a really important how to have very clearly as part of the process as soon as we know.
And if you don't feel that's captured, Vicky, I think your comments or observations on how we go about that, what you think's missing, and from just certainly from your perspective in Health Watch, that would be really very useful, I think. Anybody have any other further observations or questions? So we've got those 4 key points we're asking, we're being asked to decide on today, which is the way forward, really. But any points or comments anybody else would like to make? Dave.
Sorry, Jeff. Only just to reiterate Dave's point around the development of the model of care in collaboration and absolutely in conjunction with our locality partnerships. Now that is absolutely the next step to engage and work this through with them. They will be core to the development of it. But so what we're saying here is we're agreement in principle to develop a proposal through our locality partnerships. Yeah.
Okay. Thanks, Dave. So Colin, we're being asked to look at the process for roles and responsibilities around ICPs and ICBs, strategic financial investment principles, the process for first round of strategic priorities, and development of a community health worker model for BNSSG. That's the 4 things. I'm hearing that there's general support for that, and in principle support for taking that forward. So I'm hearing that the board is saying yes, where there are some caveats. And I think we probably do need to build in the feedback that board members have given today. That would be useful. Anything else anyone wants to add on this before we conclude? Okay, so but by me it's 1:45. What if we take a break and come back at 2 o'clock? We'll use the last hour then just to go through the committee updates as well. So if you're staying online, can I ask people to just turn their cameras and microphones off, and I'll see you back at 2 o'clock. See you all in a minute. think that's about it. So I'll get us started again if I can. So it's bang on 2 o'clock by me. So we'll do the updates from the committees now. So if we start with the Outcomes, Performance and Quality Committee, Ellen, if you want to start off with yourself, and then move to Joe and Rosie, that'd be great.
Okay, thanks, Jeff. At committee, we discussed the winter plan as agreed at last board, including hospital at home. We also talked about the LMNS, which we've already discussed at board today. Cancer performance, GIRFT, which is getting it right first time, which is an excellent piece of work focused on improving productivity and value for money. And Joe, if I can just ask, when Jeff brings you in, if you can cover GIRFT and also excess mortality and touch on industrial action, that would be particularly helpful. And we also discussed broader performance and quality. So first of all, to winter plan, you asked us to have a good look at this. The committee reviewed the plans for winter, including the national submission. And the information was reviewed by committee and was supported by, quite a significant check and challenge, I would say, from committee members to both the ICB winter leads and the hospital at home leads who attended. The committee agreed that the plans for winter were robust. However, we also agreed that ongoing review needed to be in place, and that was going to be provided by both Joe and Rosie as CMO and CNO, and that they would provide a written submission to the committee on an ongoing basis throughout winter. I think what's really important to note is, and I think the committee was unanimous in this, is that, again, this was another good example of excellent system working with trusts, Sirona, local authority and ICB working closely together to develop the plans. And also what was seen as a real benefit was early planning by NHSE that allowed Greg and the team to really get on with the planning with the trusts and with our community colleagues. So that was all seen as really positive. During the meeting, I'd just like to sort of just call out Greg Penlington, who did a really good job of presenting the winter plan, Jen Tompkinson from Sirona, and also Hugh Evans, who I don't think I've seen Hugh as positive as he was in the meeting towards the planning that had actually gone on during winter planning. At the meeting, Greg explained that each year BNSSG collates plans to respond to the winter period. There are 3 key documents. It's a winter narrative template that goes back to the to NHS England, an operation plan and a breakdown of investments. And the region have rated the plans as green and amber, and they compare favourably compared to other systems. So that was all really, really positive. A couple of key points of focus. There's lots of work going on with transfer of care hubs, NHS at home, urgent community response, but Joe, Rosie and Dave are the leads and will keep oversight of this. But what I would, the one point I'd probably make is that throughout the committee, not just on winter plan, workforce and recruitment sort of did come up a number of times. So that still seems to be a challenge in certain pockets throughout. So that's winter plan. So that was all sort of positive. Joe will probably come in and talk a bit more about some of the points there. I also just want to mention cancer performance. Again, because I've updated the board that we keep a close oversight of cancer performance. It's very importantly to note that we recognise that the cancer teams at both the Trust and the ICB are scrutinised thoroughly by the region and by the trust boards. So therefore it's important the committee is not duplicating that work. We are there to really seek assurance that the actions and the processes in place are actually effective and are moving performance on. So that's where we are actually coming from. We had a very good update from the team who sort of explained perhaps one of the issues with the cancer statistics that are drawing us back. It's on dermatology, and some actions taking place where at the moment Somerset referrals are being transferred back to Somerset, which should have an impact on the numbers going forward. But just to let you know that is an area that we will be continuing to look at. NHS England region managers have also indicated they have no concerns about the grip and the management of performance within BNSSG. So they were the key points: winter plan and cancer. We covered a lot more areas, and I'll just pass on to Joe and Rosie if they'd like to add anything, Jeff.
Thanks, Ellen.
Thanks, Ellen. Yeah, so there was a few things I think Ellen has asked me to highlight. We had, I think, a positive meeting with the National Getting It Right First Time team, led by Professor Tim Briggs, supported very ably by UHBW and MBT's operational staff and clinicians. I think there were some key messages come out. We presented that into the Outcomes, Performance and Quality Committee. I think Tim was asking everyone to increase pace and productivity. He was looking at the level of complexity that sits within the elective list and how much of the more simple procedures are going out into the independent sector. And he flashed a warning at us that if actually you don't get your balance right and you don't get your throughput higher, it might affect training capacity and training ability, because the younger doctors in training need to have their portfolio completed with lower complexity procedures. He did flash that quite a few times around a warning, so I think we need to hear that. I think he was telling us something. He asked us to do the national implement the national guide going further faster, and including the use of PIFU, which is patient-initiated follow-ups. And again, as we're looking at more demand through the outpatient system, in particular, one of these areas I'll pick up in a minute is the dermatology impact. PIFU is a way, it does seem to decrease overall demand in outpatients. So it's a way of driving, both giving patients control, but also actually making services more efficient. So he asked us to look at that. So overall, I think it was a positive meeting. I think both acutes gave a very, very good account of themselves. We take note of the actions and the feedback they give us, and that's all followed up through the elective care recovery operational delivery group. So the ICB just keeps an overview on it. But I'm sure both, again, both acute trusts are very aware of this and been briefed through their own teams. But just for the wider system, that was, and I think you would agree, Mira, I think it was a relatively positive meeting and fair. My sense, it was fair challenge on issues where he thought we could improve. Okay, I can see Maria nodding. Ellen also asked me just to touch on mortality, and I think it is worth just making sure colleagues are aware that we have set up a monthly overarching mortality review group. And the reason for that is we are still having 7% more deaths than predicted across the BNSSG system. And for Bristol, they have the highest rate of preventable deaths in England. And that's driven us to look at what is driving that. We've started looking at the data. There was some regional data initially. We've localised it into BNSSG data, and we're deep diving into where are we within sort of the UK system, but where are there anomalies? And we're starting now to see patterns starting to emerge. Very helpful also the medical examiner for the system attends, and we're trying to ask him to, although it's slightly outside his remit, as he looks at death certificates, what can he tell us from the review of death certification and discussions with families and clinicians around what aligns to some of these things that we're seeing. The one notably that we're now deep diving into is cirrhosis of the liver. So we have a very young age of death for cirrhosis of the liver, and for our lower quintile population compared to the highest, most affluent quintile, there's a 15-year difference in the preventable age, and this ranges from I can't quite remember, but it's about 48 to sort of early 60s. This is really early preventable death. So there is something going on in that population which is very localised to the BNSSG system, and so we're working that through, and I'll make sure those reports go into the Outcome, Performance and Quality Committee. And again, when we get to something that's tangible and drives recommendation for action and improvement, I'll do a summary paper back to the to the board, Jeff, but at the moment we are in interrogation and sort of exploratory phase. We're doing the diagnostic of it, saying, well, what is happening here? So I think that's very interesting. And then the other bit, which I just point out, is that we had a very good presentation from Sorority team about virtual wards. I think they were quite eloquent describing their frustrations with the lack of a shared care record. I have written round to the key people in the system, worked with Debs's team, Dan Offen in particular, and asked him, and he's done a summary of where the issues are. And he's done me a report about, look, we're trying to do a data passport, but it's about the permissions of looking at each other's records. And as we give permissions, the impact on other people who share those records. And many of our IG leads, the data protection officers, have got very anxious about some of that. So as the Caldecott Guardian and Debs as the CSIRO, with our other provider, Caldecott Guardians and CSIRO, I'm going to see what can we do to unblock this and speed it up, get to resolution, because I think it has impact on your productivity, because it means you can't redeploy staff because they can't see a mixed caseload. They have to do it based on the records that the people are using. And it's the read, we've got a shared care record, but it's read only. What we need is a record that clinicians can update the record on about the actions they've taken. So it's that interactivity that's the issue. But I just want to assure people and assure Ellen, we have taken it outside of you, Ellen. There is a plan of action. I can see Debs has put her hand up because I'm sure she's fully cited on this because it's being worked through with her team.
Okay, thanks, Jo. Deb?
Yeah, it was just to flag up, there are a series of system-wide sessions that are being developed to get us all into a space where we're really aligned in our views of what the legalities are. And we've got some legal advisors, legal counsel that are going to help us through that, so that, as Jo says, we get ourselves as a group of CSIROs and Caldecott Guardians into a space that we are totally aligned, and then we can start to develop our data sharing agreements, particularly where this is around primary uses. It's unusual for us to have such an issue. So we are actively working through that, and it will align to the shared data and planning platform, because there's quite a lot of data sharing agreements that we need to make sure that we put in place. But this one is being taken forward as a priority.
And I know it does sound like, why can't we get it sorted? But patient confidentiality is so critical as a foundation block of service delivery that it is really important that we get it right. Because when you don't get it right, if people remember that it's a connecting care disaster, it actually would put the programme back by a number of years. So I think we need to take the time to get it right, but also we need to get it done. So that's where I think Debs and I are. Thanks you, Jeff.
Thanks, Jo. Rosie, anything to add?
No, thank you. Nothing on that. And the items in the quality report are there for board to read, and I'm happy to take any questions.
Okay, and just a question of, is there anything else that you'd want to? I mean, you've brought an awful lot to the attention of the board there. Is there anything by way of decision or escalation that you would have from the Quality and Outcomes Committee, Ellen, or I mean, there's a huge amount of information in there.
Yeah, what I would say, Jeff, for me, there were 3 points. One was the dermatology Somerset activity. That feels to me that that's crucial, because the impact of the numbers are having an impact of how we might be seen by the region or further up. So I just think that even though it might be an administrative piece of work now, it's really important. So that was the first one. The second one, hospital at home. I think Jo's mentioned, they mentioned 3 things to me: a cultural buy-in across the board to support hospital at home, the electronic patient record that Jo was just talked about, and also they did talk about workforce and recruitment. And I suppose my query is, with workforce and recruitment, that might be too detailed for Jaya's committee, but it's just understanding possibly where that's being picked up across the system. And I suppose this is where it's back down to the trust. But if there's anything from a systems perspective that we need to be picking up, that would be a question. That's
Thanks,
it.
Ellen. Shane, I don't know whether you've got anything to add on that. Sorry, Joe, bring you back in now, and Rosie. But Shane, I don't know whether you've got any observations on those comments.
No, I think the issue of dermatology, absolutely understood, and I know that all providers are working that space, and it is viewed outside of our system by NHSE as a really important position of confidence. Okay, it's the best way I can put it. So it is viewed as something that we need to get sorted. I have to say the single patient record between hospital and community, it is massively important. I can't perceive this being done overly quickly, but Devs, I mean, I'm sure we'll put everything into it, but it is a really, really hard one to fix. But I think you've summed it perfectly. We understand the issues, Ellen. We understand there's things that we are doing stuff to try to fix those issues as well. And I think it's a perfect summary of where we are, Jeff.
Okay, thanks, Shane. Joe?
Just to clarify on the dermatology issue. So in COVID, UHBW did mutual aid with Somerset and took their dermatology referrals. And that has been going on since the COVID pandemic. And there have been actually convened by regional meetings for the repatriation of that work, because actually the Somerset metrics are actually much, much better than the combined NBT UHBW metrics. So it was all looking out of kilter. I've got to say, I am very appreciative of the region who actually did put their foot down and said that these patients had to be repatriated by the 30th of October. The Somerset system was asking for an ongoing prolongation of the repatriation, but the region have said no. And actually, so that actual swap of getting people back to where they belong locally has been completed, should have been completed a few days ago. But I think the Chief Operating Officer was saying, of course, actually, there is still the impact of that, and on that waiting is as they then recover their FDS target, which they think will be by the end of the year. So that's the Somerset issue. However, dermatology is a problematic, complex area that we're having to work on. We have got a workshop next week on the 10th. It is on a background of 11% increase per annum of 2-week waits going into the system. And this is because we've got an ageing population. It's not thought to be linked to COVID. This is just to do with population change. Ageing population have more skin lesions. Again, general practice can sometimes determine things are benign, but often they can't, and they need to go through a 2-week wait pathway. That's the nice guidance. Again, in the olden days, you could manage some of these yourself, you could excise them. That is not the current best practice, so they come into the system. We have rolled out dermatoscopes of practices to help their diagnostic certainty, but the use of dermatoscopes to help the input into the outpatient pathways is more problematic because it takes time and capacity. And as John has been articulating across the meeting and across the closed meeting, general practice is under a lot of pressure, both from its front door and its clinicians. So it is a complicated area. I think what is really helpful is there's national guidance came out this week on what best practice should look like. And so when we have the workshop, as well as what we think looks good with us as a group, we've also got some national guidance of expectations across the system. But the demand has increased. It's not that the referrals have increased, the demand over the population has increased over time, and that's a national issue, not being an SSG issue. So we are working that through, and we will try to get to some resolution. We've got 5 options on the table, and we're trying to get what we think is the best option. I think they will all require some sort of additional resource, however, because I think we're putting additional steps in. We're not making things more efficient, we're just making them maybe sort of clearer around the diagnostic point. But we can work that through once we know what the clinical preferred option is next week.
Okay, that's helpful, Joe. Thanks. Rosie?
Mine was on the workforce issue that Ellen raised, and she's quite right. We, in the workforce board, we look at the big system workforce numbers. I think what we need to keep doing, which Sarah's guided us in before, Sarah True-Levy, is making sure when we're looking in the planning round that we understand the workforce implications of the pieces of work we're taking on for next year, and make sure that we're always checking on the workforce options and we're not causing unintended consequences in different services when we start up new services. So we need to pick up the virtual walls bit through there, I think, Sarah.
Okay, thanks, Rosie. Great update. Huge amount of information in there. We could probably talk about those agendas all day long. I think as you go down through the system, we do, don't we? But yeah, really helpful to reassure us with the the work that's ongoing. Any other questions around outcomes, performance and quality? Okay, in that case, I'll move us on to People Committee then. Jay, do you want to start us off?
Yeah, sure. I mean, this time round we had a People Committee which was focused on ICB rather than the system. I'll quickly go through that, but I do want to go into some of the stats that we got for the system. We received updates from the Staff Partnership Forum, Inclusion Council, the Workforce Dashboard, and the ICB People Plan. Now, because we're going through a period of significant change, the People Plan requires a refresh so that it can fit with the operating model that's being determined right now. And so that the ICB functions reflect within the ICB the NHS-wide long-term workforce plan and the EDI improvement plan. So this will all be done in the new year, ready to implement from April 24. We also, for the first time, plan to have an EDI annual report for the ICB and the ICS. And previously, we only had this at the system level. The committee reviewed the draft ICB focused report this month. We'll be reviewing the ICS draft report at our November committee. There's been significant feedback already from our NEDs and around the table, and both reports will continue to be developed and will be on the agenda in February for wider discussion and consideration. So, as you know, we do look at the workforce position across the system, and broadly the position remains stable and positive in areas of recruitment, sickness and turnover, but obviously there are issues on the granularity level, and I think we do need the granularity at our committee. The broader stats tell us that since March, the workforce has grown and is above plan by 1,019 whole-time equivalents. But the reasons for this are growth in clinical support roles. They account for the largest proportion of the increase. We've also had strong international recruitment, and that plan is being delivered. There's a downward trend in turnover, which has continued since November 22 compared to September 23. Sickness at the moment we've got running at 4.9%, which is a 0.2% increase on August. Stress and anxiety is the most common form of absence. And as a system, 23% absence is attributed to mental health. So that's one to really focus on for our workforce. As an ICS, though, if you put it into context, we are one of the lowest in the Southwest region, but that doesn't make me feel any better. Vacancies are getting lower with a current 9.7% vacancy for September, and that's down from 10.3% in August. Agency is currently running with an overspend that's according to plan. Month 6 is showing a slight reduction against month 4 and 5. And of course, the temporary staffing group are continuing to work collaboratively to reduce usage and expenditure. Planning for the 24-25 for partner organisations on temporary staffing and agency is underway, I think. So that was the quick rundown, but totally agree that what we should be doing is looking at the granularity because it's impacting on specific services.
Okay, thanks, Chair. I don't think Sam is with us now, is she? I think
no, she isn't. So if there are any questions, Jo has said because she's not well, but if they can be fielded, any in-depth questions, she will be able to come back to you on. So if there are questions, do raise them. We'll minute them and we'll come back.
Okay, thanks, Chair. Rosie.
Mine's just to share a bit of positive news, and we had a really great session around preceptorship and nurse retention about 2 weeks ago, funded by NHS England, which is great. And we had lots of nurses there from across the system, primary care, acute community, and we showcased some of the work that's happening around, particularly around international recruitment and making sure the people joining our organisations and communities are welcome and stay and thrive. So lots of great work shared, which I'm sure People Committee could have cited if they'd like to, but it was a really good session.
Okay,
thanks Rosie. Yes, it would. And I think just making sure that our recruitment numbers don't hide the fact that there is difficulty when we bring people over. We do need to make sure that they're embedded and that it starts to impact productivity in a positive way. So I want to see that on our dashboards.
Yeah, I think it does. And we have a good profile in terms of retention, but there's no doubting, Jay, that we need to support people to settle in, to settle into a different way of working, because our NHS is very different, and what we do in terms of our care and treatment pathways is very different in different countries. So there's a whole piece of work that has to happen when we bring people in to work alongside us, but really positive work happening on that.
Thanks for that update, Rosie. Really good.
Thanks, Rosie. Thanks, Chair. Any questions or comments for the People Committee? No, okay, I'll move us on to finance, estates and digital then. Steve, do you want to start us off? You're on mute, Steve.
Sorry, is that better? Great. Couple of things to say. The first is that the system is beginning to work more effectively together as a system. So what we're seeing in Fed is very much collaboration and working together to try and solve issues. So that's a real positive. We're also getting some really good feedback on deep dives that we're doing across organisations, and the most recent one is Sirona. Big thank you to Sirona for giving us a window on what's going on in those organisations. It's really helping us understand where the pressures are, but also where the opportunities might be going forward. I guess that what we're seeing, Jeff and colleagues, is that there are pressures within our finances, some of them related to the industrial action and opportunity costs. We'll see whether or not those are resolved over the next few weeks. If they're not, then that's a pressure that we're going to have to absorb. It's around 13.6 million, which is at the moment not covered, and we're therefore at risk. I'd also say that we continue to see pressures in the system in organisations, which the overall, because of the organisations signalling some financial distress, the system is going to have to find a way of managing this. And we're in discussions with organisations around their current plans to reduce their financial pressures so that we get back on track. If we don't get back on track on these savings that we need to make, it makes it very difficult for us after this year end. So I think we've got to get focused on making sure we land the finances. There was a significant discussion at finance, which was around, I guess, the consequences of trying to control our finances very tightly, and then our ability to do some of the work that we want to do around health inequalities and closing gaps. And that was a big issue that we discussed as a team, and it was clearly a concern for colleagues from unitary authorities as well as from the health system organisation. So it's a shared, I guess, concern about how fast and how far we can go given the financial constraints that we're trying to manage. But I think we all recognise that if we don't control the finances, then in effect we lose flexibility in future years. So a big piece of work, I think, needed across the system to make sure that we deliver the financial positions. The good news is that we have been able to see some really excellent collaborative working to create new services and to ensure that we've got services moving forward. So some great examples that were signed off at Fed, which have now come forward to the ICB and signed off as well. So good practice, but still significant pressures. And I'm sure Sarah might want to add a few things.
Thanks, Steve. Sarah?
Yeah, I just really wanted to draw your attention to a couple of pages in the system finance report. So on diligent, that's page 860. And if you've got paper copies, it's the executive summary in the system finance report. So just as Steve highlights, we're 18.3 million off plan at month 6. 13.6 of that is the impact of industrial action. So almost we're sort of, we're hoping to understand more about the national response to that over the next couple of days. So we're sort of, our focus is really on those other variances, which is 4.7 million, and really making sure that every organisation is doing everything to get back on track. You'll see that the way we've set that out is some of that's about efficiency plans, so savings plans under delivery, but some of it's about temporary staffing costs based on primary care prescribing and some of the funded care placements. But there are some mitigations against those, but we really need to keep that focus on all of those areas. What what we're basically working through at the moment, you'll see in the sort of next steps section, 4, that we're basically looking at different organisations are sort of at different stages in terms of delivering their plan. We're particularly working through with UHBW at the moment the implementation of the protocol for changes in the in-year revenue financial forecast. So we're just working through with them at the moment. There's significant checklists that we go through with them to sort of just review where they are and to make sure that they've got full engagement of their whole board and their executive team in resolving the issues. So I think that's probably the area where we've got most work to do in terms of the financial recovery plan, but it doesn't mean that that's the only organisation with challenges. So I think we know that we've spoken before about the challenges in AWP, and also we had that deep dive from Sirona, so there's some issues to resolve there, particularly in terms of delivering recurrent savings so that we're not reliant on vacancies or slippage on investments. So really making sure that we are delivering on the savings, because otherwise we're putting at risk the medium-term financial plan, and we've got to keep going as well. So good performance at MBT at Q2, but obviously still risk, I think, in the second half of the year, and likewise at the ICB. So all of us just really keeping that focus. So those were the main things that I wanted to just draw out, but just really wanted to reinforce for everybody that, you know, we know the consequences of non-delivery is really significant this year because of that potential write-off of the brought forward debt. So we really do need to keep that focus. But is it as important is our delivery of the medium-term financial plan, because as Steve says, really wanting to make sure that we are able to deliver on those really important things in terms of driving forward our strategy. So really making sure that we are facilitating that.
Thanks, Aaron. Just having been sat in the Fed committee, it was encouraging, and is encouraging always, to see how the spotlight is put in the right places. It's very clear from the report and from the conversation that's taken place. But and I think partners around the table are playing their part, and if or when they don't, for whatever reason, it immediately bumps up and it becomes very visible to us. So I know the work that Shane's doing in the Chief Execs group, and then what you're doing with Directors of Finance is all facing in the right direction. So very positive. But Steve is right. You know, there's not a big basket of reserves, is there, to dig out our medium-term financial plan. So, you know, we do need to be all hands on the pump on it. Emma.
Thank you, Chair, and thank you, Sarah. And just to say, from a UHBW perspective, you know, we're aware that we're off track. I think the reasons have been rehearsed in this meeting anyway: industrial action, the elective services recovery funds, and some questions about what we're going to get, and then some underperformance in SIP delivery. But it's something we're very much focused on as a board. We've got controlled totals into our largest divisions, where we've got the biggest sort of drift from plan, and we're absolutely thinking about our the medium-term plan, and particularly next year, where we've got quite a large underlying deficit to resolve. So just assurance that it's absolutely on our minds and top of the agenda.
Thanks, Emma. That's helpful. And there was a conversation at Fed as well around the cultural change, which was the forensic view on divisions, particularly in our acutes prior to COVID, that cessation during COVID, which has perhaps created a different culture. And I think it's the devil's own job for you as the top team to try and drive that culture back into the organisation, which is that forensic view of the finances, because we got to a place of an assumption. I heard it said by people of, oh, they'll find the money from somewhere. Well, the money from somewhere isn't coming, is it? So, you know, I think it is a real tough job to get our top teams to be driving that back forward into our divisions and our clinicians.
I agree, Jeff. And of course, what we've got the productivity agenda as well, where, you know, at UHBW, we've got more staff than we've had against our 1920 values. And actually, how productive are we? But I think you're right. There's always been money in the back of the sofa, and it's just breaking the culture that, you know, the sofa has definitely not got a penny in it. So we need to really do think about that cultural change programme.
Okay, thanks, Emma. Marie, do you want to come in on this point, and I'll bring Jaya and Deb in?
Yeah, I think we'd all like to shake out a money sofa somehow, wouldn't we?
yeah, just to confirm, I think there is a lot of learning for the acutes going forward. We will be at the system in UHBW request carrying out a peer review into areas of potential gain between us, or areas that we can both learn from one another, just to provide some ICS assurance, but also make sure we're learning, particularly CNO to CNO, CMO conversations. Some of it will be around management of clinical spend, and then of course there are some of our corporate services work that we may wish to accelerate, which we hope will make an in-year impact.
Yeah, thanks, Maria. Jaya and then Deb.
Thank you. So you keep mentioning sofas. I do like the concept of finding things down the back of those, which brings me to thinking about estates. So do we have any better view of what we actually have as our assets? Because that's where we look to for the cash down the down the back. Do we have a better view? And if not, what are the barriers that remain? Because I know it's not easy.
Is Sarah you going to pick that up?
Yeah, of course. So Jaya, we are doing a significant piece of work at the moment on putting in, developing an infrastructure strategy across the system, so that we're really clear on where our opportunities are and also where our challenges are with our estate at the moment. So we're bringing back an update to Fed next month on that. So we'll report back to board as we go forward. We still haven't had, there was meant to be guidance released. So the infrastructure strategy, we were expecting it to sort of be a requirement. The guidance still hasn't been released, but we're getting on with it anyway, because I think we see this as being really important for us to understand where we are.
So there's still hope of some surprise money down there.
I think I'd caution. So that's obviously capital resource as well, and not revenue resource, but it is. But also I'd caution that I think when we've looked at this previously, there has been significant estate reconfiguration already in our system, and therefore we're not like some places where they've got more opportunities. So I think it's still important for us to do it and to really make sure we're clear about what more we can do. But I don't want anybody thinking that that's the knight in shining armor that's coming over the horizon.
We do have a knight around the table though, just saying.
We haven't seen your shining armor yet though, Steve.
My lance is a bit blunt.
Thanks, Sarah. Thanks, Jaya. Deb.
It was just to do the kind of couple of sentences on digital, which is we are out to advert for our shared care record, which obviously the conversation earlier is a critically important part of our infrastructure. That business case will come back. So that closes on the 14th of November. So hopefully we get our bids in and that full business case will come back. One of the things I did want to flag is that initially what everybody agreed was that we wouldn't add any additional money. We were going out for a like for like, which we all agreed would not include any new functionality like read write. However, we have included an element of understanding what it would take to take us to the next step, which is what all of our clinicians and programs are calling out for. So that will be included in the FBC. So I just didn't want there to be any surprises when that comes back. Obviously, it'll go through Fed first, and it will come back to us in January for us to make a decision. And then just to say, we've been successful in securing 650k of digitisation funds, which we've prioritised for AWP and for our community, for Serona, to ensure that we get some more functionality available for our clinicians. Those are just the two things I wanted to highlight. Thanks.
That's great. Thanks, Deb. Any other comments or questions on Finance, Estates or Digital Committee? No. Okay, I'll move on to primary care then. Alison?
Yes, Jeff, no update this month. It's bi-monthly, so update next month.
Okay, that's great. And Dave, anything else you'd want to add?
No, thank you, Jeff. Main item was obviously the system access improvement plan this month, and we've covered that in detail. Thank you.
Okay, great. John isn't with us as chair of the audit committee today. Steve, I don't know whether you're able to update. I mean, I think I was at the last one.
Yeah, I wasn't at the last one.
So the last one was a very positive update from our auditors, both internally and externally. And I think John has got a good representation at the committee and is on the right things. But Sarah, I don't know whether there's anything else you'd add to that.
No, I think there's nothing further to add from the update that John gave last month, because we haven't met over the last month. So the next meeting's in December. So yeah,
okay.
But yes, you're right. We've got really good engagement to that committee. Yeah, that's all I wanted to add.
Okay, thanks, Sarah. I'll move us on to the final committee update, which is the ICP. I have asked that in future you have the minutes of the ICP attached to the agenda, so you can see for yourselves what the conversation was there. The only thing I would reinforce is the 11th of January meeting. I mentioned at the private board this morning. That's for bringing together the Integrated Care Partnership and the Integrated Care Board to look at how we identify the areas that we work together, so that we work collectively towards the same aims rather than trying to compete with each other. So Colin's updated on some of that previously. There isn't much other than we had a change of chair there with Councillor Helen Holland, who's now chairing the committee, who's the chair of the Health and Wellbeing Board from Bristol, has moved over from Mike Bell, who was chairing from North Somerset. And then the next iteration will be when Helen steps down, we'll be moving to South Gloucester. So apart from that, at this stage, I've got nothing else to add on the Integrated Care Partnership, except in that, again, if you can fit that into your diaries for the 11th of January, that would be really, really helpful. So the only agenda items I've got left are questions from the public. Brian was with us earlier. I don't think we've got any others. I don't know whether we certainly haven't any questions tabled. So unless I see any hands come up, I'll move us to AOB. Okay, nothing. So is there any other business anyone else wants to raise? No? Okay, thank you. Well, thank you for your patience today. I know the short change to online threw us out a little bit. I think just my observation, the quality of the conversation today throughout the day has been very thorough. I think you can see the maturity of the board and how we're occupying a different space now. And thank you for your time and patience. I know it's a long day. I know it's a big take out of your diaries. And if you've got any other feedback on how we're progressing, please feed them back in. Good news to me, bad news to Shane, please. Thank you very much. I shall see you all very shortly. We got our next board in Weston-super-Mare on the 7th of December. So I shall see you all then if I don't see you beforehand. Thanks, everyone.
Thank you. Thanks
Bye.
all. Bye.